right, well, good afternoon, everyone. We're going to do a little sound check here and just make sure things are coming through in the room and online. Thank you so much for coming. My name is Daniel Vreeman. I'm an informatics investigator here at the Regenstrief Institute, where I head up the development of the LOINC terminology system. And I'm also on faculty here at the IU School of Medicine. I'm really excited today to talk to you a little bit about sharing some ideas to advance the interoperability of social and behavioral determinants of health. For those of you here in the room, we're joined by quite a good number of folks online on the webinar. And we had a little over 800 or so register to join us. We'll see how many folks share, but just by way of, you know who's who here in the room, but as we pause for questions and so forth, we'll be taking a few of the questions from our online folks as well. So as we get started, I need to mention that I have two financial disclosures to make. One, I'm president of a small business that publishes book LOINC Essentials, which is about LOINC, which is part of what we're going to talk about today. As well, I'm PI on a number of grants related to LOINC stuff, some of which are privately funded. But just to give you a sense of the small proportion that represents, this is kind of the long list of other nonprofit and federal sources who have also contributed to the LOINC work. So what we're going to talk about today is going to be divided really into two sections. So we're slated to run for about an hour and a half. We'll take a break in the middle for questions and so forth. Part one, I'm going to talk about some of the emerging perspectives on social determinants, particularly as it relates to informatics and this idea of interoperability really as one of the key challenges. Then we're going to drill down and specifically talk about the role of vocabulary standards in solving that interoperability problem. Then we'll take a break for some questions, specifically maybe about LOINC, and then come back and talk about some ideas for how to put this into practice. So this vision of using informatics as a tool to help collect and use social determinants data, and some considerations as you might be thinking about implementing that. As we get started, you might be wondering to yourself, can I get my hands on these slides? And yes, the answer is you can. After this session, we'll post these slides, and they have references at the bottom and so forth, links and so forth, that'll be available from the LOINC website. There's a landing page there already that describes some of the things that LOINC has related to social determinants, and that's where these will be posted as well. But the first thing I wanted to do to get started on this topic was share with you a little bit about the person who kind of made this very real to me. Back when I was a student physical therapist at one of the top rehab hospitals in the country, I was working on the spinal cord injury unit, and that's where I met Mr. V. Mr. V was a patient who was about 24 years old, and that put him roughly at the same age as me at the time. And he was in the rehab hospital because he had a spinal cord injury. For those of you familiar with spinal cord injury, you'll know that there's a big difference between the various levels. And C4 to C5 is where his injury was. He had partial preservation of the innervation from C5, which meant that he could use some of the muscles in his deltoid and his elbow flexors, but apart from that, very little, essentially no function of his extensors or his arm movements, his fingers, his lower extremities, and so forth. So he was a complete spinal cord injury, which meant he had a lot of work to do in rehab before he could go home. But there's more to his story, and so of course, it turned out that this injury that he sustained was actually due to a self-inflicted gunshot wound. And as I talked to him throughout this rehabilitation stay, he used certain words to describe the situation. I mean, he said he came from a place where he didn't have much. That meant he was poor. There weren't a lot of resources. He was a drug addict, a member of a gang. And his primary caregiver after he left rehabilitation was going to be his girlfriend, who had been his girlfriend for about 3 months prior. And there were a lot of things going on in his mind about how this was going to work. What would his life look like as he transitioned from the hospital out as someone who is functioning at a much lower level physically than he did before? But he needed a lot of assistance, both with daily positioning, transfers, bowel, bladder function, all of that stuff. He was going to be reliant on other people, and there was these challenging dynamics with his girlfriend, who was relatively new, integrating with the family, and just sorting out sort of the roles and responsibilities, who was going to be able to do what. And he had these ongoing struggles with depression and self-image. On the best days, he was fully engaged and wanted to help lead and train and direct his care. And on darker days, you know, he wanted to give up and didn't want to put any effort into to making progress with his rehabilitation. So it was tricky. And those of us on the caregiving team, you know, really struggled with some of these questions, particularly about his safety, because typically an individual with this level of functioning would be able to work quite well with a power wheelchair modified for him. But there were really a lot of concerns about whether he would be safe with this in his environment and so forth. So as I struggled with sort of sorting out how as a physical therapist can I best help this person, it was the first time that it really sunk into me, this major insight, which was certainly his movement system was impaired and damaged, and he had a lot of challenges with that. But that wasn't the biggest factor influencing his overall health and functioning. It was this broader set of contextual factors, both social and behavioral, that was really going to determine and influence where his functioning and health would be going forward, just as it had sort of prior to that. Of course, I knew this intellectually, but I didn't know it sort of deep inside of me. We were learning about, our perspective has been shaped by this framework called the ICF, which is the intellectual framework that helped sort of sort it out, but sort of seeing it in real life was what really, really made it sink in. So the ICF talks about, I think quite brilliantly, the biopsychosocial model, which outlines that a person's health or their condition, their states, is really sort of a collection of interrelated, interdependent things. There are body functions and structures, of course, which relate to the kinds of activities that you can participate in, which ultimately then influences and relates to your role in society, the kinds of things that you can do. And all of that is made possible through this collection of the constellation of environmental factors, personal factors, and then all of these things sort of working together. So this was sort of the framework that was starting to sit in. And now, a few years later, we're beginning to talk much more and more about how this kind of interplay it really works, and sorting out some of the more specific details of it is becoming sort of a hot topic. So I wanted to share, this is, I think, a useful framework coming from the University of Wisconsin's Population Health Institute, which sort of outlines this collection of how various factors from policies and programs, which might relate to the physical environment, the air and water quality, housing, and so forth, in addition to social and economic factors, with the sorts of other things that you might think of as traditional clinical care, how all of these things sort of combine together to create what someone experiences as their health outcomes. But there are large portions of that which are due to things outside of sort of the medical or clinical environment. And that is sort of part of the reason why we're beginning to understand better how these different determinant factors can influence it. So all that's to say that certainly social and behavioral determinants matter to somebody's health. And we're starting to tease out a little bit more about how specific factors can predict or be related to health outcomes. For example, studies have linked housing insecurity to lead poisoning and respiratory conditions, understanding about how food insecurity can be linked to hypertension, hyperlipidemia, overall poor physical health, and so forth, unemployment linked to overall poor health, and so forth. And of course, if we do a good job about assessing for these kinds of factors, that we hope can lead to better interventions and connecting with community-based organizations and so forth. And that's sort of a topic on the forefront of many people's minds. How can we identify some of these issues and help smooth the transition to find meaningful interventions and so forth? Ultimately, the idea would be if we could improve some of these social things, that will in turn impact overall health outcomes. To that end, the Institute of Medicine has published two reports that relate specifically to how social determinants and their collection, storage, processing inside of health information technologies such as the EHR is important for evolving our understanding of how to better take care of folks. And specifically, the IOM kind of went through a detailed process. I assume that many of you here have heard about this or are familiar with these reports. If not, I certainly would encourage you to look at them. Ultimately, they kind of reviewed the set of evidence, individual kinds of measures, and coalesced that down into a couple of key domains that they recommend be included routinely in electronic health records. And those domains are what I've listed here on the slide, and they include mostly individual level things, so race, ethnic group, education, financial resource strain, stress, depression, so forth. But in addition to that, neighborhood income is listed as well. So how is it that social determinants and health IT could come together to improve health outcomes? Well, some of the ideas are that by better incorporating this information into our health information systems, we'll be able to inform shared clinical decision-making. Basically having both patients, providers, caregivers have better access to the kinds of factors contributing to an individual's health. In addition, we'll be able to incorporate some of these factors into the advanced applications for diagnosis, for prediction, clinical decision support as well. Similarly, being able to integrate them better into our care pathways to route referrals, to trigger certain services to be directed towards those patients and so forth. It can be driven if we have that adequately represented in our health information systems. At the view of a health system itself, better understanding the population that you're caring with, what needs they're facing, having this information represented in our health IT systems gives us better analytics and overview information. And likewise, there's still a lot of sort of open territory to explore about the clinical utility of this contextual data. What's most actionable, what's most important, these kinds of questions still remain. But ultimately, I think it's worth asking, well, what might it enable if we do a better job of including this kind of information inside of our health IT systems? What might enable? Certainly more effective and personalized care, better population management, and I think ultimately also being able to discover new insights about these connections between some of these factors that have not been well elucidated. Man, there's a lot of challenges, which is partly why we are where we are today. So clearly, this kind of information has been recorded for a very, very long time in healthcare. But where it is recorded is often in narrative notes in the social section or the history section of a patient. Could often be done on paper. And even in the cases where we are capturing some of these data points as discrete elements, our electronic health records aren't typically using vocabulary standards or including them as they exchange data between different kinds of providers. So as a result of that, there are some missed opportunities, and we're going to spend some time talking about what that ways that we might improve that as we go forward. But ultimately, this represents a case where there is sort of limited shareability across systems is probably the norm today. But I mentioned this idea of interoperability, systems being able to understand each other. Why does it matter? So when I say interoperability, I'm not actually talking intraoperability, right? I'm not talking necessarily about an operating room. I'm talking about the ability for health IT systems to be connected and to understand data as they move from place to place. So our view of what kinds of information we need in order to make good clinical decisions is expanding. So the idea of precision medicine is sort of the encapsulation of this view, right? We're going from very, very detailed, saying I need to understand sort of the basic science and the genomics of a particular patient, all the way up through some of these more social, contextual, community level variables. And we need it to sort of all in view at the same time, not as separate sources. But that's a big challenge because we have information stored in lots and lots of different systems. What we would like is to be able to have a collection of health information systems that function like the Rainforest Canopy. So this is a metaphor that my mentor, Clem McDonald, used and I liked. he talks about the Rainforest Canopy as sort of this ideal for how our health IT ecosystem should work. That is to say, the Rainforest Canopy is this seamless web through which arboreal creatures can efficiently move to reach the edible fruits without any attention to these individual trees, right? So if you think of the data silos, both within different care settings, across different healthcare institutions, in the community and so forth, these represent these individual trees, and what we would like is them to function collectively as a canopy. But the reality is that today, most patients move faster and further than their health information. And unless you're like this guy running with your briefcase of medical records, you can often outrun your health information. So why does that happen? Well, one reason is that in each individual clinical system, discrete variables are typically represented with different codes and names. So that if you look across just the health systems here in Indianapolis for something extraordinarily common, right, a diastolic blood pressure measurement, you'll see that inside those computer systems, that variable is labeled with all sorts of different identifiers and names. And so the computers have a much harder time figuring out that these are actually all the same thing. And this happens in every domain, in every system, everywhere you look. So it's a big problem. Some of you who are a certain age might remember the song by the notorious B.I.G., Mo Money, Mo Problems. I like to say it's Mo Data, More Problems, because the idea is if we're trying to expand this view, think of that precision medicine idea, more and different kinds of data sources, we're going to run into this same issue where the same variable, the same thing is called something different all over the place. So, you know, he's saying, you know, it's like the more money we came across, the more problems we see. It's like the more data we come across, the more problems we see. And specifically, there are two main problems that we're going to talk about. One is the fact that health IT systems often lack a mechanism for exchanging data, a common mechanism for sharing data back and forth. And even if they do, inside of that mechanism, they have different ways of identifying the same concept. And so the computers have a hard time figuring it out. That sort of dual problem was the origin back in the mid-90s of LOINC, the vocabulary standard. I'm going to tell you a little bit about what LOINC is and why it exists. So it exists because of this problem. That is, different kinds of observations, of tests, of measurements have different labels everywhere. And so what the computer systems need is a universal standard to identify those things. And that is LOINC's job, is to provide consistent codes and names that computers can understand as they share data back and forth. So it was born here in Indiana back in the mid-90s, but fast forward to today, and it's used all over the world. Today, there are about 66,000 registered users of LOINC that come from 172 different countries. Last year, we added about 16,000 or so new users. And so as more people begin to adopt and use a common vocabulary, more computers, more applications, more patients can receive care in environments where the computers can help improve that process. So that's sort of the part of the solution of this wicked problem of interoperability. I just want you to recognize that we are talking about these two different kinds of standards. I know some of you are deeply steeped in informatics geekery and know this. Others of you are maybe coming from a slightly different perspective. So these two kinds of standards that we need are syntax standards, which define that overall format or the structure in which information is communicated. And those come in various shapes and sizes. There can be messages that are sent or documents, or you can use APIs. Examples of them would include HL7, version 2, CDA, and FHIR, sort of in order there. But in addition to that structural understanding, you also need an understanding of meaning, of semantics. And that's where vocabulary standards or code standards come in. For example, LOINC and SNOMED, RxNorm, for example. And the reason is that you often will have things that look alike, but are actually different. So here, what we're trying to do is distinguish meerkats from meerkats. So they have similar names, but they're quite different meanings, right? So we want our computers to be able to pick out things that are meerkats from meerkats. Humans are better at it than computers. But there's no one standard, one single vocabulary that covers this entire landscape perfectly. So in the context of social determinants, you'll want to think about sort of a collection of vocabulary standards depending on what particular kinds of things that you want to do. We're going to focus a fair bit on LOINC because many people are starting with this idea of assessment, of screening, of recording observations about this kind of content. But if you're interested in coding this information as a problem or a diagnosis or a condition, then a different kind of vocabulary such as SNOMED or ICD is useful. Likewise, covering the landscape of medications might require a terminology like RX norm and so forth. Well, let's focus a little bit on LOINC and about the space of observation. So overall, LOINC covers a pretty wide territory. There are about 87,000 variables that are inside of it, but you can think about it in some of these different categories as I eliminated. So many people know about LOINC for sort of its laboratory test data and basic clinical measurements, but there's also codes that represent the spectrum of down to the genomic level, things that are being recorded, as well as lifestyle and environmental things as well. So your observation could actually be, your unit of analysis could be about a single person, a patient, but it could also be about a nursing unit, or it could be about a community, or it could be, in a veterinary context, about the herd, or it could be about the census block and so forth. So your observation could be pertaining to different levels or units of analysis. But LOINC's purpose is quite specific, right? So I keep using this word observation. And what I mean specifically by that is these structures where you have a variable, which is your test or your measurement, then you have some other place, some slot where you store the answer or the result value. And there are a couple different kinds of structures, right? Different syntaxes. You might use old HL7 version 2. You might use an XML document like CDA. You might use a FHIR resource to communicate that, but it's that same structure. There's sort of a question and an answer. And LOINC's big job is filling the slot of telling you what that observation is, what that test is. So in this example on the slide, I've got a numeric example of body height where the result value is a particular number correlated with its units of measure. And you could sort of transform this into lots of different structures, but that role is the same. I need somewhere to identify that observation. And if you're a geek and you've heard all about this FHIR stuff and you want to know more about how LOINC and FHIR fit together, I'll share with you this link about a presentation I did not that long ago that kind of went through that. So LOINC has these codes that represent and identify different kinds of observations. It also creates codes for packages or collections of those observations. So a single test result might be a body weight, or you could think of it even as a total score on something like the Audit C questionnaire. But then LOINC creates these codes for these collections. We call them panels that organize individual observations together. The collection codes are useful because they could be used sort of as an order. So you can order one thing and it returns back a whole collection of things. So there are LOINC codes for such things like a whole instrument, like the PHQ-9, or one of the promised item banks. And then that sort of parent panel code is linked to all the constituent individual observations that might be related to it. So here, for example, is showing sort of the panel breakdown for the PHQ-9. So there's a code that represents the instrument as a whole, and then each of the individual questions on it also gets a LOINC code and the total score and so forth. And this sort of hierarchical structure and this other information that's showing on the screen is all part of the LOINC distribution. In addition, each one of those individual observations can be linked to a structured answer list. So I was giving the example of body weight before, and the answer there is just a number with the unit of measure. But in other kinds of questions, the response set is a nominal collection or an ordinal, like a ranked list. And LOINC has a way to represent those things as well. So here's an example of a list from one of the promise items that shows you sort of the choices that are available, and it can be associated with a particular score that could be summed into a total value and so forth. So LOINC has this idea of a collection, which is the panel, the individual items within that, and those items can then be linked to structured answer lists that give you the response set, and each of those are assigned codes as well. And for more information on sort of how that works, there are a couple of papers that describe our big model for representing all of this stuff, and I'll leave you to dig into that later if you really want. So how is it distributed? So LOINC has 2 major releases twice per year. We always are adding new stuff, and there are a lot of different release artifacts. I'll show you just a couple of examples of the files that come into it, but I want to also point out that there's an online and desktop browser, as well as an API for interacting with the LOINC terminology content, plus some documentation. So the LOINC release has all these different files in it, and specifically in the context of social determinants. To get at sort of this overall structure, there are 2 sort of really important ones. One is that main LOINC table, but in addition, there's a file that has those answer lists connected to LOINC terms, and then a file that has the organization of the panels with the parent-child relationships and so forth. But if you just want to poke around and see what LOINC has, what kinds of variables that are there, you can start by going to the online search browser, just search.loinc.org. And if you start typing stuff in, you'll get results back. So here, for example, I'm searching for, I just put an ACE panel to look for the adverse childhood experiences set. And if you click on one of the codes in the row that comes back, you'll be taken to that details page, which shows you all the information that we have about that particular panel. So here's an example showing, that top level code and all the different items that are within it. And if you scroll down in that display, you'll see each of the different questions within that set, its answer lists, and so forth, all sort of bundled together. So you can get to that right from your browser and start searching. We also offer this desktop mapping program called Realma, and from there you can do the same type of thing. You can search what's in LOINC, whatever the latest version is, and so you can search there, you get results on the grid, and then you can view those details as well. But there's also a little bit of a nice feature inside of Realma that helps you visually sort of poke around at this kind of content. And so if you go to the View Panels and Forms menu item, it will be taken to this sort of tabbed view. Way up at the top is a collection of tabs that organize these LOINC panels. And on the far right side is our collection of patient-reported measures or survey instruments. And they're organized into some broad categories. And here, if we go down into social environments or some of the other categories, you can sort of visually see what top-level collections that we have. So I've highlighted one row here, which is the HARC questionnaire. And if you click on that, you'll get the details, which is, that overall instrument, and then the individual questions within it, the total score, and so forth. And if you scroll down there, you get the same level of detail for each of those questions. So there's files that you can download to get it, tools for browsing, but I also mentioned briefly our newest addition, which is an API to interact with this. So if you're a real geek, you might know FHIR, in addition to having API standards for organizing medical data, also has some terminology services capabilities. And we've deployed some of that here on the LOINC website and made the LOINC content available sort of through this programmatic interface. So here's just a quick sample. The nice thing is that it makes it a lot easier to do sort of dynamic on-the-fly queries about particular LOINC codes and their answer lists and so forth than was ever possible before. So if you just want to get, basic information about your favorite LOINC term, you can pass this URL in with the code, and what comes back is the FHIR resource for that code. Here is a question about food insecurity from the U.S. Food Security Survey. And in the same way you can get information about the codes, you can get those answer lists, the response sets that I talked about. Those are structured as FHIR value sets. And so you can pass in the identifier for that value set, which is our LOINC list code, and come back and you'll get the whole set of allowed responses to those questions. So all of that is new and fun, and if you're interested in exploring from sort of the technical side, you can certainly do that. And I've written up sort of a detailed set of tutorials and exercises that you can get that'll help you sort of walk through what's available and the different commands or operators that you can use. But some of you might be just interested in seeing sort of the landscape of what currently is represented. And the short answer is there's a lot, but I'll be the first to say it's not enough. So there are currently about 10,000 different terms that are organized into these different collections. And you can sort of scan this list and see, I just made a couple of selections about the different kind of content that's in there, but a couple sort of stand out. So the first is almost all of the promise items are in here. And so that's a large collection, probably 1,000 or so variables, as well as a whole set of terms from the Phoenix measures, which includes a whole domain related to social environments. But the other section I'd point out is the set of terms that was included in the 2015 Meaningful Use Certification criteria. So that is a criteria around capturing social and behavioral data in electronic health records, and the collection of items that was drawn from that IOM list of prioritized domains. The ONC pulled together sort of the short set of questions that sort of fit those main domains, and that list is drawn from LOINC codes for each one of those. And you can grab that whole collection from LOINC as well. And so it's been published and is available. I'll mention briefly that when content is included in LOINC and distributed in our release, it's available for free worldwide for both commercial and non-commercial purposes. So it can be incorporated into electronic health records or other systems that are sold, and there's no cost for transmitting any data that's coded with LOINC and so forth. There's really only one main thing that the LOINC license prohibits you from doing. So you can't take LOINC codes and use them to make some other standard for coding observations, because that sort of defeats the whole purpose of having a standard in the first place. But any of the content that's in there, which would include things that we made based on or derived from other instruments, is available. That representation, the LOINC representation, is available for free at no cost. But one question you might be asking yourself is, what if I can't find something that I want or that I need? If you have a particular measure in mind, where do I go to find it? And if you poke around, you can't do it. You can't get to it. Well, vocabulary standards like LOINC grow or get stuff added because the user community asks. So first thing, don't invent your own coding system. You don't need to. You can use LOINC and you can add to it. In particular, though, we're part of ongoing discussion in this particular space, which we recognize is very broad, and there's still a lot of sort of work to figure out what is the best collection of measures to start screening with, and that might vary by setting and so forth. Specifically, LOINC is interested in adding codes that represent items or assessments that have an open license, open IP, meaning they won't get mad at us for including it in LOINC, and we don't have to pay oodles of money because we won't do that. Two, focusing on things that have been adopted by consensus. So when the professional community comes together and says, you know what, this question or this set from Cardia or from PHQ is the one that we really want to use, and here's this community of people that want to do that. Those are things that LOINC says, yes, of course, we want to make a set of codes for those so that the communication can happen. So the broader the consensus is around the importance and the purpose for collecting it, the higher it sort of gets on our radar. And you can make requests for this kind of content just by going to the LOINC website, and the section on submissions describes what kind of information that we need to create new codes. And our team is ready and willing to add new content and can help you sort of work through that. But I say all this stuff about LOINC and setting up that discussion about how it works within HL7 to make one major point, which is that when we're thinking about social determinants, we need to think about standards because we want that data to be portable and understandable to different computer systems throughout the health ecosystem, thinking from wherever it's captured and whoever might be capturing it the first time to all of the later downstream uses of that information. That's sort of the value of standardization, helping computers assist in that process. So I want to pause there and see if there are questions just sort of about LOINC or about the broad topics that we covered thus far. And then we'll come back and talk about some implementation sort of things. But any questions just about LOINC and its approach to representing this content?
We do have a couple. Can you hear me?
I can.
Okay. We do have a couple of questions online. One of them is, are there examples of how people are using LOINC codes for SDH or mental health, such as like the PHQ-9 or the PHQ assessments in clinical environments or things like that? Like, are they currently being used, I think, is one of the main questions. The LOINC codes themselves within systems.
Yeah, so that's a great question that I don't know all of the answers to, but certainly we're getting requests from, for example, Mayo and from vendors like Cerner who are adding this content in. Likewise, the other set of requests often are coming from quality measure developers who are building out measures that are calculating whether or not certain assessments or screens were performed, such as a screen for depression. And the way that those are being articulated, those measures are being articulated, is by sort of enumerating those set of codes that might be there to capture it. So while I don't have a list of organizations, I know that it's starting to happen because of those two things. One is the set of people that are asking for additional codes coming from both provider organizations and vendors. And the second is the developers of quality measures who are sort of setting up the architecture for that by defining the code lists themselves. Yeah.
Okay. We have another general question I think that would be helpful just for people to hear about, but in terms of implementing LOINC codes, there was someone who asked about how systems, it seems like systems would need to be built with these codes, and so how can they implement them if their system's already built, they're already using the data? And
Yep. Yeah, that's a good question. So in general, most health IT systems have a mechanism for adding new variables, right? And those are typically defined, you might call it a dictionary, a data dictionary of some kind. And typically those are defined with local codes or codes that are specific to that institution. Sometimes they start with a collection that's provided by the vendor. And each institution typically has the ability to add more and more of those to their system over time. In addition, though, what we need is a mechanism to link those local or internal identifiers to standard vocabularies. And all of the major health IT systems today, the vendor systems, have a slot, a field of a place to store an association between a local code and a standard code. And this is part of sort of the evolution over time, but is required for the meaningful use certification for lots of other domains, not just specifically in social determinants, but for laboratory reporting or collecting vital signs and so forth. So there is a place to associate a standard code with that, and it's sort of you might think of it as a mapping table, right? And so that is part of what would need to happen to implement the LOINC codes. First of all, you have to place in the system, and you have to make that pairing of, oh, for this variable that I'm capturing, here is the LOINC code that represents that same thing. Then, of course, to make use of it, there's probably a second level of thing that needs to happen. And for analytics or reporting purposes, you could make use of that table, that pairing table, that mapping table to search by LOINC code. But if you want to share that with somebody else, to send it to a different system downstream, that might be your primary care clinic, or it might be, a community health center or something. You need a technique for packaging that result, that data point up, and associating the LOINC code from that table into that outbound exchange. So today, lots of kind of exchanges are being done with CDA-based XML documents. So practically speaking, it might be associating that LOINC code with an observation entry inside of a CDA. And typically that, is a function that's possible, but you have to work with a specific vendor and institution to figure out how to make that happen. But you need this sort of pairing of a mapping table first before you can do that output.
Okay, thanks.
Okay.
We have quite a few questions. I don't think we can cover them all online, but
sure.
I don't know, maybe another
one?
Maybe
take one more. I think just as a quick note, hopefully I failed to mention this earlier, but if you are online, you can enter your questions. We're not unmuting everybody, but you can enter them in the question field, and that'll get sort of queued up here, and we're sort of reviewing them now. We also will review the questions that you pose, even if we don't get a chance to discuss it here. And we'll try to follow up in some sort of summary way to address things that we think we have something useful to contribute, but we don't discuss here.
So additional question is, are there examples of LOINC SDH data being used to inform healthcare reimbursement policy?
That is a good question. I do not know that there are. So that requires, a couple things. One is that the information is coded or has been mapped in some way to LOINC identifiers for those things. And then second, that aggregate information is being used in a policy or a reimbursement or some kind of decision-making process. And I don't have any specific knowledge that it is happening. That is from our position here at LOINC. Nobody has told us that they were doing that. That doesn't mean it's not happening, but I don't, to my knowledge, I haven't heard about that yet.
Okay, thank you.
Yeah. Okay. All right. So let's talk a little bit about sort of the implementation side of this. And the idea here is to follow sort of the core sort of informatics mantra, which is to be able to collect something once and to be able to reuse it for multiple purposes. That might be in the context of clinical care. It might be in the context of reporting or quality management or research of various formats as well. And so the first thing, right, is to make sort of a decision that it's important to start capturing this key data. And there are a lot of sort of great examples of people who have started describing their approach here. And throughout the next couple of slides, I'll point you to a few of them. In particular, this is a nice paper by Rachel Gold and her colleagues talking about developing an EHR strategy for health center patients, specifically around capturing social determinants of health. And what's really nice about their description is they sort of walk you through the thought process of how do they get people across these different centers on board, how do they think through who's going to collect it, what are they going to do with it, and specifically they were starting on this idea of screening and assessment and then sort of making that process smoother for identifying who should go to what kinds of resources as they existed in the community. But it starts first, right, with a decision that you want to capture this, and you probably want to capture it in a structured way. Now, you could deploy sort of NLP or other advanced techniques to sort of extract structure from narrative freeform things, but absent a process that sort of makes it routine to capture this, it becomes a lot harder. And so you'll have more variability in how or when that information is captured. So if you want to sort of go the route of capturing these items as discrete data, you have to sort of start thinking about, well, which ones and how and so forth. But there are informatics tools or techniques that you might use to sort of streamline the process. So one example I want to just show here is an open source JavaScript toolkit that's developed by the U.S. National Library of Medicine. It's called LHC Forms. And this application software can run in the sort of Smart on Fire ecosystem. So it can actually be plugged into any of the major EHR vendor systems as a sort of add-on module. But what it does is it reads the LOINC panel definition. So the way that LOINC sort of organizes and relates collections of information and the items within it and the allowed response sets, it reads that definition and makes a data input screen from it. And so it sort of understands, well, the question text and what responses are there, the score values, and so forth. And so I'm showing just an example of that whole collection from the 2015 edition certification criteria from ONC. That collection, you can pull that whole thing up as a panel and display it as sort of a data input screen as well. So certainly it's possible to build these. Other organizations have gone through and sort of custom built within their EHR environment the forms that would capture this information. But I just want to show an example of something that can read sort of the standardized definition and present it as a form. But then it comes back to this question about standardizing at the source. So I'm recommending that you think about doing that standardization as close to the data capture point as you can, so that all of the downstream benefits come as that information is sort of passed between systems. And so, for example, in that little data capture widget that I showed, it can output the results, if somebody fills that out, as a collection of codes and response values using FHIR or other HL7 messages and so forth. But having that information standardized sort of up front means that any receiving system can operate on the standard codes and doesn't have to do its own mapping or translation between your local thing and what the standard is. So then you also though might want to think about, and there are a couple of really nice examples about community level data. So specifically, you know, the screen on the last one was sort of more oriented toward collecting patient-reported information, sort of screening for factors by having a patient or the caregiver respond to it. But there are certainly other kinds of social or contextual data that can be aggregated, whether at the census tract level or other kinds of geographic levels. And asking the patient about that isn't really a good idea per se, but bringing it in sort of on the back end through APIs and associating that with individual clinical records is an approach. And this is illustrating an example here from Michael Cantor at NYU, who has described their approach to using open data and connecting that to making that available sort of in aggregate. So you've got sort of individual level data, and you've got community level data that you might scrape together or piece together from various sources within your geographic area. And then what can you do with that? So certainly having a standardized representation of this allows all of the good stuff that we've learned in informatics over the years to be possible. So for example, building sort of if this then that statements about if a patient screens positive on a particular item, whether that's their stress score or whatever, and maybe you also want to build in something that accounts for whether the patient has indicated that they have a willingness to have help in this particular area. You know, if those two conditions are true, then automatically sort of route or initiate a care management plan or specific pathway within your care system following that sort of initial screen. So building out sort of the rule system that makes these individual items sort of actionable is certainly possible and cool. In addition, the aggregate data can be used for lots of different applications. So for reporting or analytic purposes, you might want to ask, you know, the question, for whom have we done social isolation screening? And by querying the database using codes that are understood by the computer, you can sort of figure out, oh yeah, if one of these different protocols was initiated anywhere in the system, then you know we know that social isolation screening was performed. Or you could calculate sort of the exact percent of patients within your population who have had a particular score or passed a cut points for any of the key measures that you might want, right? Whether that's food insecurity or stress or physical activity or whatever. But the idea is that having the information represented in a way that the computer can understand makes it much easier to build these kind of reporting, analytic, or aggregate view things. So that whole idea, right, is that the same information can be used, captured sort of once, and reused for multiple purposes, for better informing clinical care, for building out population health analytics or registry capabilities, for doing electronic quality measure analysis, for doing other kinds of epidemiologic or observational research, and so forth. So that's sort of the idea, the vision. And there are a few examples of people that are really kind of leading the way in that. But I wanted to give, based on some of that experience, just a couple of suggestions or questions for you to be asking as you might be thinking about implementing a health IT plan around capturing social determinants. So the first idea is to recognize that this problem that I've talked about as interoperability has a technical dimension to it, but ultimately it's actually about people who want their health IT systems to work together and to understand each other, right? So I say that just because this is sort of a people problem. We need to try to understand who's collecting it, how that's being collected, and where it can go, sort of independent of or alongside of the fact that can we get the technical systems to actually do it in a way that they can understand. And so recognizing sort of this social dimension to the interoperability problem is, I think, key. If you just approach it from a technical side, you'll run into some trouble. So the other sort of big idea to get started with is that when it comes to standardizing health data, despite the fact that I'm sort of in the standardization side, sort of the business of standardization, I'll be the first to sort of say not all health data is worth trying to standardize, meaning there is sort of a return on your investment that is variable depending on the kind of information. So where should you start? Should we standardize everything? Should we just try to tackle sort of a couple of key variables? And I guess what I would say is starting with things that have a high degree of professional consensus around this is the way that we want to capture, this is how we understand it's important. Things that will, if I capture it in a certain way, in a routine way, it will actually save me time because of what I can build into the application to make more efficiencies. Is it actually actionable by the person who's collecting it or in close proximity to them? Is there a business value that I can understand and contemplate around the standardization of that information? What can I do that will add value to my business? And if people are already doing it just in a less uniform way, these are all sort of pointers that will say, yeah, this is a direction, this is sort of an area that's worth investing the time of doing sort of this standardization work. But recognizing that the field is still relatively open and there are questions about what kinds of information we should collect, and you might not want to sort of tackle the standardization for everything. You might want to sort of see how things shake out and build the value proposition with some of these factors in mind as things evolve. But here are a couple of questions that you might ask yourself as you're thinking about how to implement an IT strategy to go alongside your overall organizational strategy with social determinants. So one is, how might I build consensus about selecting a social needs screening or assessment tool within my community, within my area of practice, with whatever set of health centers or providers that I might be working on. That's not a trivial matter per se. And there is a fair degree of, even if there are sort of published examples of standardized sets, where in this discussion about consensus building, is this the set that we should use? People want to make choices or tweaks or say, well, this one we don't think is relevant in our area. And really, I think in order to be successful, there has to be consensus from the people that are collecting and using the information. And so it's worth sort of thinking about and developing a plan for that as you get started. In addition, I'll just point out that we've seen this in other areas. It's important to pay attention, at least a little bit of attention, to the intellectual property aspects of any instrument that you might use. So elsewhere in medicine, people have sort of gotten burned by thinking they knew or understood the license terms of an instrument, but then later figuring out they didn't and had to pay money or got in trouble and so forth. And so understanding that context with whatever sort of screener items or forms or questionnaires that you want to use, what is the sort of the true license, and are there any restrictions that might prohibit me from using it? As we've been talking about, what kind of clinical vocabulary might I need to build into my application? And, if you're focused on sort of screening or assessment, then LOINC is a logical choice. If you're interested in coding sort of the specific observation, the specific interventions or diagnoses, there are other terminologies that'll be appropriate there. Am I going to need to request any new codes? And then this question about how the heck do I actually integrate them into my EHR? That was sort of the question that we talked through a little bit at the break. And then thinking about how are we going to optimize that data collection workflow? And, what does that mean? Who's going to collect it? Who's going to review it and so forth? And how or where should I capture patient preferences about social determinants? So that is, even if we might know that there's a need, if the patient has indicated they don't want our help with it, we shouldn't maybe bug them about it every time they show up, right? So this is kind of a set of starter questions. And I'll point you to a couple of resources for folks that I call sort of trailblazers in this. So the first is the Siren Network, which is run out of UCSF. And this group has a fantastic website that catalogs a whole collection of tools, resources, evidence around implementing social determinants in your care system. And I think you should start there if you're looking for somewhere to start. In addition, on the screen there are sort of two papers here that I think are really nice illustrations of people who have described their process for getting started. And the first one talks about how 6 different organizations developed tools and processes for social determinant screening in primary care, and it walks through that sort of decision-making process, what they ended up selecting, and so forth. And then the second one is specific to health centers and talks about their implementation experience as well. But just kind of as an example of some of the resources that are on the Siren website is this great tool that sort of breaks down each of the sort of main or popular or available screening instruments and kind of lays them side by side and illustrates, okay, how many questions are there? What domains is this going to screen for or assess? And kind of lays them all out. So it lists, the Accountable Healthcare Communities tool, the Prepare instruments, and others, and sort of lets you compare them at a glance side by side. So that's a really nice resource for getting started. So then, as you start to sort of think through how you might apply this within your system, I think it's useful to ask a couple of other kind of questions, which is, in what ways are we going to really sort of put this data to use? And that's part of sort of driving the buy-in from people, which is how am I going to derive value from it? That might be in the form of, computerized decision support or more tailored or efficient care pathways and so forth. And part of that is understanding, well, which other care team members might benefit from having this information, and how might we share it with them, meaning, who's going to collect it and where is it going to go? Surveying sort of what other resources are available to help with this. And then I guess I would ask 2 other kinds of application questions. The first is, I would love to encourage a broader conversation or participation in a community as we continue to learn best practices for doing this. And I think the folks at the Siren Network have done a good job of facilitating that community. Certainly from LOINC's perspective, we're interested in listening and participating in that as people sort of work out what are the best practices, what are the best instruments, what are the best tools or application strategies, and then to sort of think about, what are the opportunities for innovation. And I think certainly there's a lot of room for innovation in this space, and it really is sort of a nascent area, but one ripe for innovation. So some of the resources, just to mention, that are available in sort of that application side, I mentioned the Prepare tool, which is really a nice screening and assessment collection. And there's an entire sort of implementation and action toolkit that walks through sort of your thinking around each of the items or domains or areas that this tool sort of screens for, and then how do you operationalize the kinds of responses that you might get from that tool. And it kind of walks you through each one of those areas. It's really, really a nice resource. The Siren Network has also put together a sort of a current state compendium of the sort of vocabulary codes or vocabulary standard codes linked up to items in the the main sort of assessment sets. And it includes LOINC codes and SNOMED codes and ICD codes, I believe, as well, and kind of looks through each sort of question or each domain or each area on these things and tries to sort of lay out, well, what are the codes that correspond to those. And I think that's a great starting point as well. And then last, I'll point out this resource from CHCS, which talks about some nice descriptions of implementation considerations in populations that have pretty complex needs. I would also mention that the Office of the National Coordinator has published this document called the Interoperability Standards Advisory, and it is a sort of a pre-regulatory working space that outlines for certain areas or interoperability needs, what are the standards that are relevant, recommended, or used in this area. Within this standards advisory, there's a whole section related to social and behavioral data. And currently, it describes sort of the key domains that were outlined by the IOM that were included in that meaningful use criteria. And it has references to the LOINC codes that represent them and so forth. But from the informatics perspective, I think it's worth sort of commenting about how you would like to see this particular area evolve over time. Do the standards fit the bill? Are you using them? Feedback about that, other areas that you'd like to see added, and so forth. This particular document is open for public comments right now. And so if you're working in this space, I think it'd be great to have additional feedback on this particular thing. So I want to just sort of close by saying that I believe that there's still a lot to learn here. I think the idea of how to best incorporate both individual level data and community level data is still sort of a question. Whether that's done sort of in the back end on the dynamic basis, if you're actually going to try to persist information at the community level in the individual record of a patient, how do you do that? Do you store that in the EHR, or is it always sort of a dynamic call? There are lots sort of informatics questions about that, but I think just information use questions as well. Additionally, thinking about how to tailor this approach in different kinds of settings, acute versus federally qualified health center, very different sort of kinds of settings. So how might we tailor this approach in those different ways? I think also closing that feedback loop. I mean, a lot of work now seems to be on the sort of getting things started, the screening assessment, and then driving that initial referral. But I think understanding sort of that whole loop of what happens after the referral, how do we understand, how can we better support providers who might be on the receiving end of that, and so forth. There's still a lot of sort of informatics work to be done to make that a better ecosystem. And partly I say this because I do believe that in the informatics community, we're going to need, it'd be useful to have a research agenda around social determinants informatics applications. And there are a number of folks who are interested in this. I think Michael Cantor is a leading sort of thought leader here, and would love to hear your input on what you think are sort of the key high priority research areas in informatics in this particular area. I also want to just close by saying, we believe that LOINC can be useful in this for identifying these things, but recognize that there's a lot of area yet for growth where we might not have codes for the particular variables that you need, and so would welcome requests in this space. But the take-home lesson here is, once you get data represented using data standards, then these particular data elements, these social determinants, can be shared and understood by lots of different health IT applications for the benefit of many. And I think we're just beginning to sort of see this take place, and it'll be exciting to see how it unfolds. but I would encourage you to sort of get started and take the next step. So with that, I'll finish and open up the floor for any closing comments, discussion, questions.
Once again, we have quite a few online.
I thought
so this is great. So one question is, does LOINC make an effort to harmonize codes for SDH data? For example, several instruments may capture similar or related SDH data, and when request is sent to create the codes, does LOINC ensure that similar questions have the same code regardless of which collection instrument the question may be part of?
Wow, that is a fabulous question. So let me see if I can try to answer it. So at the most basic level, LOINC tries to represent the specific granularity of the way a variable is assessed or captured. So in general, we represent terms with the level of fidelity at, in this case, a question. And so different instruments might have different phrasings or categories or different response sets that are all kind of about the same domain, but they have very different sort of conceptualizations. And in general, LOINC creates different codes for these. Now, we've had a lot of discussion about this, and in general, we've been sort of motivated, in part informed by sort of the psychometric perspective, which is pretty rigid about what's the same and what's different. We're not super rigid about that. We allow for some punctuation differences and so forth. But in general, we try to keep that level of fidelity of difference. The idea being that the more aggregate or the roll-up thing is something that can be done on a use case basis. The reason is it isn't always clear who wants to aggregate what. And so in general, we don't create this sort of super parent generic code. We keep the level of fidelity of the way that people are phrasing it. That being said, we don't create codes for sort of every random extrapolation or phrasing of a particular question. We're sort of anchored by well-established, well-validated, commonly used measures. So just because one institution has a particular question this way doesn't mean we'd necessarily create a LOINC code for it. But there's sort of an evolving conversation around at what level is it useful to create more general codes. And I think that's a conversation we'd love to participate in, but in our current state, we aren't typically doing that, except to the extent that we might have like total scores for instruments and so forth. But some like overall assessment, the question would be, is it persisted at that high level, and is it shared between people at that high level? And what we've observed so far is mostly people are sharing sort of the more high fidelity sort of question answer responses of the total scores. So that's a great question, and that's my best answer, but I would say that is also an ongoing conversation.
There is one statement online that is very true from Charles Snyderman. He mentioned that unlike most clinical and laboratory observations, SDH observations are not routinely made and then, much less described with any consensus methodology. And that's kind of the problem, that we're trying to solve. But and then if it does get into an EHR, it's often in that NTE or note comment segment. So yes, we agree with you, and we're very aware of that. So I thought that was a good point. We have another question. Are there legal barriers for collection and sharing of SDH data? So I'm assuming this means sort of in the clinical/privacy context. Yep. And I am not an expert in the field, but I would assume that it falls under the same guidelines as other kinds of patient-reported information, meaning that, yes, there has to be sort of consent to share, just like there is in sort of a general another healthcare context. But I'm not specifically aware of any additional layers or concerns about this kind of information. But in general, it's sort of your obligations are governed by who you are. And if you're a sort of
HIPAA-covered entity, that's sort of one set of things, versus if you're not acting in that capacity, you would have different kinds of constraints.
Okay, thanks.
Yeah.
We have a question about how could organizations outside the clinical environment, such as community-based public health intervention programs, be encouraged to adopt standards like LOINC?
Wow, that's also a great question. So there are multiple ways that adoption of standards sort of can happen or materialize. And so, one direction or one thrust can be the context of a regulatory environment or a rule or something that is sort of mandating use in a certain way. But and that has sort of a place. But there is also sort of prior to that or outside of that, the sort of business value that's gained from the adoption. So most adoption within the U.S. is sort of happening because business partners decide that it's more efficient to do it this way than it is to each independently sort of make their own sort of systems and figure out how they talk, because it's a problem sort of a scale. It's like when you only have two people that you want to exchange with, you can sort of sort it out, you can figure it out. But the more exchange partners you have, the harder, more complex that particular problem becomes. And so it's at that point when the people that are sort of interacting with each other can sort of voluntarily decide, yeah, we want to, by consensus, adopt a set of standards because it's going to drive efficiencies in our operation. So to that end, I would say initiating sort of the conversation around, well, what are the benefits of being able to aggregate, share, and build applications that make use of this information? And I think that would be sort of the starting point for thinking about how to build broader adoption. I mean, there is also, I would assume, a question of awareness, or perhaps a lack of awareness of the sort of IT or informatics technical concerns about the fact that this is actually even possible, that people have thought about how to make systems interact with each other. And that's hopefully is what we've tried to talk a little bit about today. But I don't necessarily see a regulatory thing as being required in order to drive adoption.
Yeah, I was going to say too that I think one thing that's really nice is there's a lot of work that's being done in terms of capturing that data, public health data already, and standardizing it. And so organizations that are just beginning to look at it and figure out how to standardize their data could look, like at CDC and others and how they collect it and what codes they're using. So it's not like they have to maybe necessarily start from scratch. There's a lot of work that's happening out there, and I think probably just by talking with different organizations, local public health, all over, that they might be able to have somewhere to start, that they don't have to start from the beginning. But
yeah.
I don't know how many more questions you'd like, but
let's maybe just take like one or two more, maybe.
Okay. We have a pretty common question. Is there a table with translations from LOINC to other code systems like CPT and ICD-10?
Yeah, that's a great question. And the LOINC distribution does have some mappings to other external terminologies, but specifically in this space, there really aren't any mappings. And so just to kind of dig into the question a little bit. So in general, because a LOINC code would represent a question and its response value, the combination of somebody answering this question and what choice that they make on the response might be, you could maybe infer a particular diagnosis code from that, an ICD code or something. And so it's kind of the question answer combination that gets you that. It's not necessarily always this question has a mapping to this other sort of condition or problem or diagnosis code. We don't have those associations today. We don't. Likewise, the linkage between LOINC and CPT is a sort of a many-to-many combination. And specifically in the social determinants sort of screening area, there aren't tons of sort of CPT-related codes that could be used, but LOINC's level of granularity is a much more specific one. It's sort of at that level, whereas CPT tends to be about the procedure or the process or the kind of evaluation that was done. So they're at sort of different levels. But and specifically, there are IP licensing challenges with LOINC to CPT mappings that we were not able to overcome, despite putting a pretty good effort into that 5-10 years ago. So unfortunately, no, there really aren't, to my knowledge, the kinds of mappings that I think the user the participant is asking about. So
I think lastly, we have several questions related to additional content in LOINC, and like with NCQA or maybe even CMS or a lot of different instruments out there. Maybe you could speak a little bit to how we add that new. I know you talked briefly about it, but maybe just add how we add that content, or the questions are related to whether we're going to be adding this new content or.
Great. So maybe just a little bit more about that. First is that if you are curious about what's in our queue today, you can go to that link that I mentioned before, loinc.org/submissions, and then if you append to the end of that queue or follow the link on that page, you'll find a link to the queue. You can actually see the entire list of codes that have been requested and search on it and so forth. So you'll always know sort of what's on our plate sort of at the time. But the more broad question of how does this new content get in, we do routinely get requests from both users of LOINC in healthcare settings or vendors who are building out their application that wants particular instruments represented in this way, or organizations who are developing quality measures who want to express a automatable rule that articulates what kinds of measurements would be counted in this quality measurement. And so if we want to count the percent of patients who have had a depression screen, NCQA or NQF or any of the measure developers want in the measure development definition to be able to make it automatable about what counts in that. And so that becomes a process of defining a value set of sort of appropriate or valid in that context depression screening instruments. And it's there as the measure developers are kind of working through that logic that they might have sort of this list of known instruments or widely used instruments, and then they're finding codes for it, and they say, oh, but you don't have, recently it was the Beck depression inventory or whatever. And so it's in that process that they then request, oh, we want to add this because it's being used in this measure, we want it to be used in this measure. And they make a request to Registry to add that content. But specifically, what does it mean? There are different sort of ways in which we can create codes in this area. The sort of full-blown model is, they say, well, I want this whole instrument, this whole form to be represented. And we then get sort of that request and then work through, well, what's the panel code? What are all the individual question codes and answer lists and so forth? Occasionally, we're not able to sort of do that sort of full set of things, either for IP reasons or because the user actually say, well, nobody actually is transmitting the individual questions, they just send the score. So, can you just have a code for the overall score? And that is an approach that we can do as well. So we can add content that represents just sort of that overall final conclusion or final score or whatever as well. But those are, that's some of the ways that it happens, but the mechanisms that generate it. But ultimately, it's a request from a particular user who wants to or is using this variable in their system. Yeah. Great. Well, thank you all for participating, and happy LOINCing, and look forward to hearing from you again soon.